So I am presenting today for Terrographics International Foundation, TIFO, and I will discuss a lead poisoning epidemic in Nigeria, which was first discovered in the year 2010, but continues today. So I'm very pleased to be here, and I thank you. Next slide. Next, please.
Je vois juste sur la flèche. Je vois pas où la flèche du film PDF. Ah oui, elle est. Alors, je te prends juste la main 10 secondes.
I wanted to show briefly some of the places where we have worked around the world dealing with humanitarian health, often related to environmental pollution. And the three areas that I have starred, Nigeria, Kyrgyzstan, and Bangladesh, are projects where we have worked with Médecins Sans Frontières. I know there's some people from MSF here today, so I wanted to highlight that. And I'm going to speak, of course, about the project in Nigeria. Next slide. There we go. And in the upper left corner, you see the states of Zamfara and Niger. This is not the country of Niger, but the state of Niger in Nigeria. And these are the two states in the Northeast where we have been working. Next slide. So the background, in 2010, MSF discovered this unprecedented lead poisoning. They were doing immunizations for meningitis and polio. This is an area where polio still exists. And they realized that there were many young children that were missing. And they learned that 500 children had died within the past 6 months, 30 to 40% of all children under age 5. And you can see the picture in the corner of the graves of some of these young children. MSF immediately opened a clinic to begin treating the children under extreme emergency conditions. They found that probably 30,000 people had been severely poisoned, including many under the age of 5. Next slide. Every child and every adult that they tested was lead poisoned, and the levels were extreme. The geometric mean blood lead level was 150 micrograms of lead per deciliter of blood. And the highest level ever recorded in a living human being was 700. We used to say that over 100 was certain death. They've never measured levels this high in any population. Next slide. So how did this happen? It was a combination of things. The price of gold was and remains very high, and this population is very poor. They were mining in colonial lead mines. There was enough gold in these lead mines for this to be economically viable in this population. The mines were over 10% lead, but they were seeking the gold. And this is done in an Islamic part of Nigeria where they have purdah, and the women are not allowed to leave their households. They're sequestered in their households. So the women and the children were participating in breaking the rock, breaking the ore in the same vessels where they grind the corn and the grain. And you can see the woman and the little girl here are pounding grain, those same containers they use to crush the rock in part of the mining process. So the women were actually involved in the process. And in the picture below, you see there were also children directly working at the mining areas. Next slide. Well, we know a lot about how children get lead poisoned. And one of the things they do is they eat dirt. They ingest soil, incidentally, hand-to-mouth activity. And this is true for children in rich countries, in poor countries. It doesn't matter where they live. In the United States, we know that a 2-year-old child ingests approximately 100 milligrams per day of soil. So if that soil is highly contaminated with something like lead, that's how they become poisoned. So one of our sayings is we need to give them clean dirt to eat, uncontaminated soil, if they're going to do this hand-to-mouth natural ingestion of soil. Next slide. Because of the extremely high lead levels, this was a multi-stage process. MSF, of course, did the blood lead testing and chelated the children. Many children were chelated. But if you're chelating children, you must return them to a clean environment. If they were chelated and returned to a contaminated environment, they would actually take up more of the poisoned material, more of the lead. So our job at TIFO was the remediation to reduce the exposure. And this had to happen simultaneously with the chelation. At the beginning, MSF ran a hospital, and children were brought to the hospital under very severe conditions. Next slide. But in this, as I mentioned, under PERTA, women were confined to their compounds. So they really couldn't bring the children to the hospital. They had other children to take care of. So the logistics of children going to the hospital became very difficult. Next slide. So instead, what MSF did is they developed outpatient clinics in almost all of the villages. They had remote access, and the children would come to the village, they would get the blood lead tested, they would get their chelation drugs, and they would be given doses to take home. So you can imagine the logistics of tracking the doses was very challenging in this project. The chelation drug that was used was Suxamer. It was delivered with a peanut butter called Plumpy Nut, which is also important for the nutrition of the children. Next slide. Meanwhile, our job was to identify all of the paths of exposure to the children. I mentioned food already. Storage of food in contaminated soil was an issue. You can see in the upper picture the very fine dust, the contaminated soil that was all over these villages. There were 10 villages total, so it's a huge area. Children working in the mine, using contaminated soil to make bricks to build the houses. And we also tested the water. Often in places like this, people think, oh, it must be contaminated water. Actually, at this site, the water was not contaminated. The largest portion of the contamination came from the soil and from the food. So our job was to break these pathways of exposure. Next slide. Go back one if you could.
Sorry.
One of the most important things that was done initially was to move the ore processing out of the villages. Because your conference focuses on the rights of women and children, this was actually very important environmentally, but very difficult culturally, because it meant that the women could no longer be involved in the job of mining. For safety, for health and environment, it was important. But for their social interaction, it was very difficult, because this was one of the few things that they could do to participate in employment. But the ore processing was moved out of the villages so that this continual generation of contaminated dust and soil was moved out of the area where women and children lived. Next slide. In this picture, I'm testing the interior of a house. I'm using an X-ray fluorescence device to test lead contamination on the soil. The insides of the houses, as you can imagine, were also highly contaminated. Next slide. And we also had para-occupational exposures. This young girl is selling food at the mining camp. So she's young, she's allowed to go to the mining camp, sell food. Any food that is left over is, of course, even more contaminated from the camp, from the mining area. She brings it home. They ingest that food at home, and she's probably also carrying contamination on her clothing when she returns home from the mining camp. Next slide. In addition to lead poisoning, we were dealing with malaria, cholera, and one day there was even located a guinea worm. Next slide. The remediation involved many, many thousands of samples. So we sampled the building material, the food containers, the households, the farmland, thousands and thousands of samples. We surveyed people. We tried to identify where children lived, how people were being exposed in every part of the community. Next. We hired hundreds of local people, local villagers, to help with the excavation. So here we are removing the contaminated soil. Many of these same villagers were also miners, so they knew a lot about moving dirt, and we used the local equipment in as many places as possible. So people were learning how to remediate, how to clean and excavate their own areas. Next slide. And then we brought in, this is another picture of the excavation. Soil was removed, it had to be disposed. And then we had to bring in the clean soil. Next slide. So here we're bringing back uncontaminated soil. We're having to make the surface safe. So we're all the time testing with the X-ray device to make sure that the contaminated soil has been removed before replacing with clean soil. So this is where we said we give the children uncontaminated soil to eat, to ingest. This is part of what we're doing. Next slide. Of course, the soil that was contaminated had to be disposed of, so we had to build landfills and bury that contaminated soil in a way that it was permanently removed from exposure to people. Next slide. As you would imagine, the soil lead levels dropped dramatically in reducing exposure. We have followed up on these measurements for many, many years, and you can see that in about 2016, there were some spikes, some places where the soil lead levels went back up. This is because in some families, they were again bringing material that was contaminated back into the households. So we had to work with the local emirate. The religious government was extremely powerful here, the local government, the tribal government, to make sure that people knew how to re-remediate the areas that had become recontaminated. There weren't so many of them, but sustainability is always a problem in these projects. And it's one of the reasons that we continue even today to try to continue to monitor the soil to make sure it is not a significant part of exposure. Next slide. The blood lead levels, most importantly, also dropped very dramatically. I told you at the beginning, the geometric mean was about 150 micrograms per deciliter of lead in blood. It almost immediately dropped. It has never dropped as low as we would like. The chelation courses, this particular slide is before chelation. So this showing the drop in lead levels only due to reducing exposure, which is critical. And then of course, chelation takes the lead levels down even more. But this particular graph is showing only from moving the ore processing, protecting the food supply and cleaning the soil, removing the contaminated soil has a huge impact on reduction in blood lead levels. Next slide. This has been a 12-year effort. We have in total remediated 10 villages in Zamfara and Niger State. MSF has treated over 8,000 children with chelation. This is probably the biggest chelation project ever in the world. And unfortunately, they have only been able to treat children under the age of 5, even though we knew there were many more older children and adults that needed chelation. The reason for this was there was not enough chelation drugs in the world for this project. At one point, almost all of the chelation drugs on planet Earth were in this part of Nigeria treating these young children. And of course, young children are the most susceptible. So that was a difficult decision that had to be made to only treat the young children. Within 3 months, childhood mortality had dropped from over 30% to under 2%. And at the same time as doing the remediation and doing the medical intervention, we also developed a safer mining program. Now, I don't say a safe mining program, but it was safer than it used to be. They were using mercury. We found substitutes for mercury. We found ways to make sure that this processing was not done in the villages. And most importantly, we were training and hiring local people, because this was a project that we knew was going to continue as long as they were mining. And the villagers had to be involved in understanding the health effects and how to reduce the environmental contamination. Next slide. In 2018, MSF and the Nigerian federal government sponsored an international mining symposium, and the special focus was on preventing environmental and health effects. This was a huge event. This was 8 years after the initial discovery of this epidemic. And the man at the podium here is the emir, the religious leader of Zamfara. He was a huge partner in this project, which I always sort of have to say, I never thought I would say that, but he actually helped the villagers understand the contamination of the food supply and how dangerous it was to do the ore processing in the households. So he probably saved thousands of lives with his very strong intervention in how this project could continue. A real important part of this conference was initially the government just said, this is all illegal, we should ban it, and we should make all these people be considered as criminals. And TIFO and MSF said, please do not do that, because people will continue this activity at night. We will not be able to help them. We know you can't stop it. You won't be able to stop it. So finally, they began to understand that this was really a form of subsistence mining, part of how poor people were, and the fact that farming had become more difficult. And the vice president of Nigeria at this meeting made the statement that children should not be sacrificed for mining. So this was a huge step. Of course, as health professionals and environmental professionals, we would like to say, of course, you shouldn't be mining gold in a lead mine. It's very, very dangerous, but we knew there was not enough constraints for preventing people from doing this. So it was more a process of making it a safer way to live. Next slide. This is important because this kind of mining is huge around the world. The World Bank estimates 100 million people are involved in artisanal small-scale mining. Almost half of them are mining for gold, because the price of gold is high, because of poverty, and because of climate change. And remember, these are not people working for a mining company. These are individual people. The gold industry benefits from having all of this labor without having to really pay them a salary. They don't have to pay any insurance, any retirement. All they do is come around and buy the gold. Next slide. This slide I like to use because it shows that in Nigeria, the climate crisis is already happening. It is a conflict between farmers and miners. The miner says, I have to eat. The farmer says, so do I. Next slide. In northeastern Nigeria, there are lots of conflicts between the Hausa farmers. This person is from the Hausa tribe. Next slide. And the Fulani tribe, which are nomadic herdsmen. Next slide. So because of climate and the loss in agricultural production, both the Fulani and the Hausa, there's a lot of tribal violence, and they turn to mining. Next slide. So here again is a picture of a miner and all of the dust and soil contamination that can result. Next slide. So now in Nigeria, this has become an even more complicated project because of violence. In the villages where we worked, thousands of people have been relocated into displaced persons camps, refugee centers. I think of them as climate change refugees that Médecins Sans Frontières is operating in northeastern Nigeria. So many of the same people that lived in these villages, because of the violence, the women and children are now living in these camps, and the men often are still going every day from these camps to go mining.
Okay.
It's been very difficult for MSF to continue to monitor and do the things in the villages that we were doing remotely because of this local violence. Next slide.
Yeah.
But we do feel that it's been a successful project. It's been very challenging, but we say if you can do environmental remediation in Nigeria, you can do it anywhere. It's a difficult country to work in. It requires a lot of political will. It's important to give local employment to make sure that the people are actually involved in the project, developing the local institutions like the Ministry of Health and Environment. And it really is not that expensive in terms of the richness of the metals economy. In this project, the media played a very important role. There were a lot of news stories about this project, and it helped influence the government's response. And of course, the role of NGOs like MSF, TIFO, the Human Rights Watch, and many others were important in getting this to work, because originally WHO, the World Health Organization, the Centers for Disease Control were involved, but they really don't stay involved in these projects like the NGOs do. Next slide. How do we really measure success? Well, this child was born into a clean environment. He was born in one of the first villages that was remediated, and he became one of our symbols of hope, that he could be born into a clean environment. Next slide. And these children are playing on lead-free soil, on uncontaminated soil, without being lead poisoned. Next slide. Throughout this project, we had many partners. I was surrounded every day, we all were, with many, many children who were interested in what we were doing. So we had lots of partners. They were the fun partners. Next slide. And we also had many other partners. I've mentioned MSF. We worked very closely with the state, local, religious, federal, and village governments. So many, many forms of governments. Many other partners were involved, and we're very grateful. We thank them for their involvement, and I thank you for your attention. Yeah.
Thank you very much for this highly interesting presentation on lead, women, children, poverty, Nigeria, and traditional practice. Any question? En français, quelques questions?
Oui, je passe le micro.
Frédéric Sorge. Thank you for your presentation. Do you know at which cutoff do the children were treated for lead poisoning? And second question, until what age would you think children would have to be treated?
The protocols for chelation, MSF had a committee actually that evaluated this all the time because the levels were so unprecedented. And I mean, most of the protocols, they chelated the children down to about 25 or 35 micrograms per deciliter. Now, in France and in the United States, that would be a lead poisoning epidemic. That level would be so high that we would say, you know, this is a crisis. But in this area, they were starting with such high levels that they chelated down to maybe 25 or 35. And then when they were moved back into a clean environment, we observed that they would establish an equilibrium between the environment and the blood of about 10 to 15, which is still too high, but it's probably the most we could hope for. They only chelated children under age 5, but if they began chelation, let's say at age 5, then as the children got older, if they needed it, they would continue the chelation, I think maybe for 1 or 2 years. But you know, that was one of the real ethical crises of this project, that there was not enough logistics and chelation drugs for the older children. And of course, many of these children, when they become childbearing, they have the bone store of the lead that then goes to the fetus. So the follow-up on maternal health care in this particular project really does not exist as we would like it to, because of the numbers of people and the logistics of the violence in this region now.
Dr. Sako, for Mali, I think this study is very interesting, and I think it will be extended in other countries, because there is the same question in other countries. Thank you.
Yes,
have you understood?
Yes, I think so.
It's not only Nigeria.
Of course. And the fact that there was gold in the lead ore, many of the geologists said that's impossible, because they didn't understand how poor these people were and how expensive, you know, how rich, expensive gold is. The other big source, so that particular ore is a little bit unique, but the biggest problem globally is with battery recycling. That exists all over the world. People are probably more lead poisoning in poor communities now than ever before. And because of the recycling of car batteries, the recycling of lead, we had a project in Senegal right before the project in Nigeria where 30 children had died in Senegal because of recycling of batteries. And so this is a problem that is absolutely global. And, you know, we hope never to see anything quite on the scale of Nigeria, but lead poisoning is still a huge problem around the world. Absolutely.
Last question. Did you test a pregnant woman?
I'd have to check with the MSF data. I don't think so. I think most of the, well, probably testing, yes, but I don't think any of them were chelated. I think there were a lot of adults tested. I think I mentioned that every person tested in these villages was lead poisoned, but there really was not the resources to intervene with medically treating these people. The best treatment we could provide was to reduce the exposure in the environment. But of course, we knew there were children being born being born lead poisoned simply from the in utero exposure. And in these communities, if we think about not only the deaths, but the loss of every health effect. I mean, you know, all the neurological effects, the kidney effects, all the health effects of lead, also the IQ, the leaders in these communities, the whole generation of leaders that has been lost in these villages due to lead poisoning. It's one of the real tragedies of this project.